So Brian, this is very similar to what you just reported at ASCO. So the patient's observed due to low volume disease, as opposed to starting. It's somewhat indolent. He wants to avoid toxicity. So from your data that you just reported at ASCO, what does the practicing physician need to know in terms of how long can one safely follow, when to start to think about intervening, what are the triggers for a change?
Yeah, so I mean, I got that question asked a lot of me at the poster is, when do you start treating? And what I would tell patients is that it was for one of four things. It was, new sites of disease. So this patient develops liver mets or something that gets your attention. Increased pace of disease. So they're kind of perking along, and then all of a sudden they get a scan or two that you think, gee, there's more disease there. There's acceleration of disease growth. Symptoms from disease, which I think would be too late, and I don't think anybody in our study developed symptoms. We didn't wait until anybody developed symptoms. Or doctor or patient anxiety, if people just got anxious, which also never happened. Patients love not being treated, by the way. So really it was sort of those first two, probably the second, just you get that gestalt that there's more and more, and they're getting to the point where their lung nodules are not 6 millimeters, now they're 2 centimeters, and that's very subjective, so there's no equation. But it's kind of one of those things when you see it. But I think that's evolving. I don't have a firm answer.
So in this case, the patient went on and was observed for another couple years, now 11 years after his nephrectomy, continued growth of his pulmonary lesions and the appearance of a new paratracheal lesion. They made a decision to start systemic therapy with sunitinib, 50 milligrams, 4 weeks on, 2 weeks off. Pretty much had a classical response, tolerated the therapy. But then after about 14 months, now we're in June of 2012, developed new disease in his liver. So he has pulmonary mets, new disease in the liver, clearly progressive disease. Danny, how do you pick that second-line therapy?
Yeah, so I think it's difficult to know exactly which second-line therapy to choose. There isn't a specific biomarker that we can say, oh, we should use this drug, of course. And so obviously the choices are axitinib or everolimus because they're phase 3 randomized controlled trials addressing that population. In this patient, I choose axitinib. He has liver metastases. We're looking for a good response. And I would want to make sure that he is getting some sort of a side effect. And if not, I would try to titrate the dose up.
So Brian, you were the principal investigator on that trial. Give us a sense of how often you can dose escalate. What are the criteria for dose escalation? Do people do better with dose escalation, or is it just an exercise in dose escalation?
So a lot of questions there. So in the AXIS trial, about a third of people dose escalated. That had more rigid criteria. In the frontline trial that was also published recently, about half the patients were able to dose escalate. And that's probably in clinical practice, a third to a half can tolerate dose escalation. As much work has been put into dose titration with axitinib, it's still unclear exactly how to do it. The trials had clinical criteria mostly based around blood pressure about whether you could dose escalate or not. The frontline trial, which had a randomized cohort of titration versus not, did show a objective response rate advantage to titration, but not a PFS. And some of that may have been that the schema for titration was fairly significant steps up. So some people would step up from 5 to 7 twice a day, have toxicity, and go right back down. That's not really titration. And it didn't account for some of the nuances we talked about of either an in-between dose like 6 twice a day, or going up to 7 but just taking breaks. Right? That kind of thinking wasn't really part of it. So I think there's benefit to doing it. It's not based on blood pressure changes or not. We can't dose people to a particular PK, to a particular drug exposure. We've looked at all that data, and it's again frustrating for as much as you try to look on how to optimally dose, that we really still don't have the optimal way to do it.
And Chuck, are there any economic considerations to dose escalation?
There can be. Usually by the time we dose escalate, they've already surmounted the insurance and economic barriers, so we don't experience that as much. Okay.
So even though you're actually going from 5 milligrams to adding 1 milligram tablets up to 7, economically that has not a pressure on the patient.
It doesn't come to my attention, I don't know.
And so for this patient, they get dose escalated, tolerate it, hypertension's controlled, and let's assume that the patient then has a response that lasts a median of how long, Brian?
Median duration of response in the AXIS study, I think it was probably 12 months, I'm not sure.
So it goes on for another year.
Yeah.
And here we're faced again with the fact that he's got growing liver disease, growing pulmonary disease, has been through almost 2+ years of TKI. Amazing for a patient with kidney cancer in 2014. Jan, what are your choices now?
Well, your choices are basically what you haven't gotten. So one would be an mTOR inhibitor. One would be a clinical trial if there are clinical trials available for people with prior therapy, which may or may not be the case. One would be immunotherapy. I mean, this patient is a classic immunotherapy patient. 9-year disease-free interval, 2 years before he had to have any TKIs. You might want to look at some of the newer immunotherapies, the vaccine trials or nivolumab or some of the other checkpoint inhibitors, because he's demonstrating that indolent course that gestalt-wise, clinically, would make him a candidate for an immunotherapy trial.
Yeah, and I think this is just a classic case of how different kidney cancer is now than it was even a decade ago. And a person like this having remissions that last for over a year with first line, over a year for second line, and now facing third line therapy is a testament to really the accomplishments of everybody on the panel and everybody that investigates kidney cancer. So this has been a great discussion. We've reviewed a lot of information on the therapeutic advances in renal cell carcinoma and several key cases in the community oncology practice. I'd like to get some final thoughts by our panel in terms of where we are, where we're going, and whether we missed anything in terms of transmitting this information to our colleagues in the community. Chuck?
Well, I'm an old timer here. I've been in practice a long time. So the young physicians coming out of training now don't know what progress we've made. It's been amazing. Kidney cancer, especially in the last 10 years, is night and day. It's a lot of fun to take care of kidney cancer patients now, a lot more than it used to be.
Well, we're happy to do that. Brian?
I mean, I think, we touched on, for targeted therapy, I would say find a drug you're comfortable with, figure out how to give it. Don't be afraid to schedule, modify to maintain dose. Use your multidisciplinary team to manage side effects and really try to squeeze every last drop of efficacy out of your existing targeted therapy. And then I think what's coming is PD-1 agents. And I think when we're sitting here in a year and 2 and 3, we're going to be talking about that as a standard frontline therapy. And then where do the targeted therapies fit? I think it'll sort of flip-flop. Nice
problem to have.
Yes.
Jen?
Well, I think my feeling is we haven't yet, after 25, 30 years, optimized IL-2. And I think we have to look at schedule and perhaps combinations at a different dose with the checkpoint inhibitors. I think the immunotherapy investigations are where we're going to be going in the next year or 2, including the vaccine studies. But I think we really need to relook at how we can put the stepping on the gas with immunotherapy, taking off the brake with immunotherapy, and choosing appropriate candidates for immunotherapy will take us forward into people that have decades-long remissions.
And Danny, how's the international consortium going to contribute to our knowledge, and your final thoughts?
Yeah, I hope that the IMDC will be able to do mass biomarker evaluation and look at more of the pathologic characteristics and biomarkers as opposed to clinical markers, as we've done so much in the past. In terms of the future, I'm actually really excited about the future. The clinical trials available and the different agents that we can use are just remarkable. And I would encourage as many patients as possible to be enrolled into a clinical trial, because how we got here was because people in the past were on clinical trials.
So I'd like to thank the panel, and on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. Thank you very much.